Good morning, good morning. All right, we are here for the final few hours to bring a outstanding conference to a close. I am just so happy. If those of you who saw me yesterday when they played, the guys over here played the happy song, it was just like, wow. I think it was Jose who came today that said, let's play some salsa music so we can start dancing the salsa. So maybe that's next year. But I really thank all of you for hanging in there to the very end. This, I promise you, will be just as good as the very first day. You're going to learn so much. But, you know, I am really on a high, even though this is the end as we're coming to close, because this has just been a wonderful opportunity for us to get together, network, share, and have the depth of presenters. So I promised Alex I'd only take a couple of minutes, but those that know me, that I just so revved up, and I'm so appreciative of those coming together that we can think, we can plan, we can problem solve together. So thank you again as we end up our session, wrap up our 2.5 days. Alex.
Thanks, Karen, and thanks to all of our panelists who are here today. We're a slightly smaller group this morning, but we're a dedicated group, so congratulations to all of you for sticking through. We know it's a long event, but you know, there's so much good work being done out in the communities that we didn't want to, we can't shortchange that work. So there's a lot of work to be done. It takes time to do that work. For this morning, we really wanted to focus in on really expanding clinical models beyond just the provider and the patient, and talk about partnership. And just with that in mind, I wanted to take a minute or two, and actually before I do that, sorry, I got ahead of myself. Again, you've got an evaluation for this morning's session on the pink sheet in front of you, and in your handout materials that you got when you registered, there is an overall evaluation, so please do complete those by the end of the day. You can either leave them on the tables, leave them in your breakout session, or bring them back to the registration table before you head out. For anyone who just came in this morning and needs continuing education credits, there's information in your packet. Back to partnership. My wife and I will celebrate our 6th anniversary in a couple months, and she runs a health center in Philadelphia, so I like to say that I provide technical assistance to public housing health centers 24/7. One thing, and she's very good at her job, she's also terrible at laundry. It's something that I've learned over the years. She just, she puts it in the washer and then walks away, and 3 days later we have mildewy clothes. I happen to love doing laundry, so in our partnership, I've learned not to partner on the laundry. I just do it my damn self. And that's an important lesson. If you can do something yourself, you should. It's easier. Partnership is work. It's hard. But honestly, it's the only way to get the things done that we need to for our communities. So this morning, we're going to present one partnership model. We hope that you'll think about it, think about how you, as Kent said yesterday, you can learn from it, but then do something with it once you get back. So without any further ado, please welcome Marilyn.
Hi, I'm Marilyn Wideman, and I am from Rush University Medical Center in Chicago, Illinois. And I want to say good morning to all the diehards, everybody that's here seeing the conference through to the end. Thank you for staying. And this morning, our panel is going to discuss, and are the slides on already? Or should I? Okay. Our panel is going to discuss a demonstration project that's aimed at addressing workforce development needs of current care providers, evaluating current models of care, and testing new healthcare interventions for the purpose of responding to the ever-changing healthcare landscape, with the whole purpose to provide the very best care and decrease health disparities for underserved populations. Building Healthy Urban Communities, which is the name of the project, is a multifaceted 5-year project that includes multiple partners, as you can see from the cover slide with all the different names and all the different logos that are up there. But the focus today is going to be on the Better Care Teams portion of the project. which includes development, education, and training to the current providers. But before we get to that part, I'm going to give a brief overview of the larger project to provide the context for where the Better Care Teams lives. And then Beth-Anne Christopher, who's the director of the Better Care Teams, is going to give an in-depth review of this portion of the grant. And Peg Dublin, we're so happy could be here with us. She's a representative from one of our FQHC partners in Chicago, Access, and she's going to discuss why she thinks a Better Care Team type of product is important to have, and what she hopes, or her FQHC hopes to get from this project. So this slide is a model overview of the Building Healthy Urban Communities project, which is nearing the end of year one. And the first year has mainly been a planning and development year. We have had a couple of projects that have taken off running faster, like our community health worker program through one of our city colleges is ready to launch, and a wellness center we developed has launched. But the bottom two lines that you'll see are really the underpinnings of the project. It's development of a cadre of health disparity fellows and a rigorous evaluation plan. So before I give this brief overview, I really need to say a couple of words about the partnerships that came together to do this work. Malcolm X College is one of Chicago's city colleges, and Rush has been in partnership with them for many years now to assist with their transition to the Health Science College within the City College group. In the Chicago City Colleges, I would say Malcolm X has the bulk of the healthcare programs already, but a variety of the city colleges have different programs. So the programs in the other colleges will be closed down. Everything will be consolidated at Malcolm X to be just complete Health Science College, and with that, new curriculum streams, new programs are being developed. So some of the things that areas, I should say, that we'd already been working with them well before the start of this project has been with such things as faculty development, curricular revisions, and healthcare career ladder programs. So with Rush being an academic medical center, we've been lending our expertise to them as we can. And we're also neighbors. We're right down the street from each other. The medical home network, which is very interesting, as you see on the slide, it's a Medicaid network, and it has a contract with the state of Illinois as a Medicaid provider. And this was actually started through private funding from one individual whose intent was to provide better care for the underserved populations on the south and west side of Chicago, and those are areas of very, very high need. And she provided the seed money to get this going. And Rush has been part of this project since the idea phase. And in regards to the demographics, it's a really wonderful partnership. We have 6 FQHCs with a total of 118 sites, 5 safety net hospitals, and then Rush, being an academic medical center, is the tertiary care center. There's shared data, meaning through the IT portal, we can see what our patients are doing at any time within this whole medical home network. And one really cool example of this that I like to give, because this one FQHC has it down really well, when they see their patients in emergency departments, they have quite often had a community outreach worker in that emergency department talking to that patient before the physician is even seeing the patient. And the Medicaid lives, or the lives that we cover, it's well over 170,000 now, and bracing to go up much higher very, very soon with county care that we have in place, provides medical homes, and as I said, there's this real-time electronic connectivity. And lastly, I would really be leaving something out if I didn't talk about the partners that provide money. At Rush, we have a very large philanthropy department who's been very helpful with us in securing funds. Of course, there's been private funders involved and foundations. BMO Harris, Bank of Montreal, funds many projects like this, but what they told us, they're all funded at separate institutions, so they may do something on education here, healthcare there. So what was really appealing to them is that we could do the whole package all in one. And Rush, as the PI, holds the funds for this. And what this funding has really done, it's helped us to bring all these partners together that already existed, so that's very important. We were already working together in mutually beneficial ways, and we brought people together who hadn't been working together and then accelerated what we were already doing with everyone. And as I mentioned earlier, the goals center around the healthcare workforce development and employment. And you may say, why employment? Well, we don't want to help create useless degree programs. We want to get things that are really going to address the health needs now and in the future, and where people will be employable, and then improved outcomes for the underserved populations through sustainable models. So nothing goes away, so it continues on when the funding is done. So now into, briefly, the different components for those columns that you saw on the overview. Malcolm X College and Rush has worked with the medical home partners to identify their workforce needs for the purpose of developing new programs, associate degree programs and certificate programs, and career ladders for seamless transition for their students either into Rush University or any other university of their choosing. And like I said, the one that's ready to launch now and that was worked on very hot and heavy from the very beginning is the community health worker. And while that's not the focus of this presentation today, during the question and answer period, if you have questions about that, Beth-Anne knows quite a bit about the development of the community health worker program. The overwhelming, it's important to know that the overwhelming majority of the Malcolm X students come from underserved populations and from the neighborhoods that Rush and the Medical Home Network serve. So with that, it's been necessary for Rush to provide other financial supports for some, I would really say a majority of the students, to achieve their healthcare career goals that go well beyond the examples that you see on the slide that you're looking at. Okay, another part of the program, which I said is one of the underpinnings, is our Health Disparity Fellows. And they are evaluating every aspect of this project, and they're also evaluating current medical home network care models, and they're developing and testing new care models in areas of high need within the medical home network populations. They're looking at decreasing the unfounded ED use, which having this shared IT portal is just so instrumental with that, and developing healthcare curriculum streams. And we've also built in supports for our fellows, which are listed out on the slides, and I have to say, having experienced mentors and the ongoing training for them, even though with the 5 fellows, 4 out of the 5 are PhD prepared and one's mastered going into a PhD program, but we purposefully chose early careerists as the fellows to develop them further and to set them on a lifelong path of being a health disparity researcher. And then for the community investment piece, which was one of the buckets, Rush has a long history of community investments through such programs as RCSIP, and that acronym stands for the Rush Community Service Initiative Program. So we used the BMO funding to expand our health services that we were already providing through RCSIP to Housing First residents. Now, I would venture to say probably, if not everyone, most people in the room know what Housing First is, but in case anyone does not, it's a model that provides permanent housing to the hardest to serve of the homeless, and the hardest to serve is identified as those with chronic mental illness and/or substance abuse issues. So we have the Wellness Center up and running fairly quickly. We did our baseline evaluation data in October and November, and the Wellness Center was running in earnest by January. And I have to say, has already been producing excellent, not just lifestyle choice changes, but actually health status change for the Housing First residents. And we're also measuring the outcomes for the Rush University students that we have involved. And I always look at involving students in these kind of activities as pipeline training, and you may say, but they're already healthcare students. But pipeline training to get these students excited and energized about wanting to work in the community, understanding about underserved populations, and how to work along with the community actually for real needs, not what you think is your good idea for someone else. So some of the student outcomes that we've had to date include such things as enhanced understanding of community needs, improve skills in client-centered care. Instead of that, this is what I think is a good idea to do, and working with the community, not alongside, but actually with them to build need-based programs. And then the sustainability for this piece is actually built in through having it to be faculty and student-led, and also bringing it into the RICSIP program, because I get funding from Rush, as I call Big Rush, every year to keep all of our RICSIP programs going year after year. And then finally, which I'll be brief on because Beth-Anne will now go into this piece, the Better Care Team portion of the grant, as I already said, is training for existing providers. And through our work with the Medical Home Network, when we were dreaming up this grant ask, we at Rush and others in the Medical Home Network suspected, and suspected is an important word because then Beth-Anne drilled down to find out what was the real need, but we suspected that there was a need for new skill development in response to the needed revisions that we all have to do with our current models of care, to work effectively with all of the emerging healthcare worker roles, and the landscape is changing, and the newer team members who now hold novel positions, things that are very different from what we're used to, and to effectively communicate with providers across the entire medical home network. And we know it can be difficult enough sometimes communicating effectively within our own organization, but we have to work and care coordinate throughout that whole network of all the FQHCs and hospitals that are involved. And lastly, we thought there is probably a real need with folks in using data in real time through integrating data extraction and application into the daily workflow. So the focus is on providers, physicians and nurse practitioners both, care coordinators, and the outreach workers. So I'm going to turn this over to Beth-Anne, and she's going to drill down into the gap analysis for what was really needed, or what is really needed, and then her and her team's development, implementation, and evaluation plans for the Better Care Team.
Good morning. My name is Beth-Anne Christopher, and I am from the Rush University College of Nursing. And I just want to thank all of you for not just your time here this morning, but for all that I have learned from all of you. I feel like I've made many new friends, and I really appreciate all that you have been willing to share. So thank you. So the Better Care Teams, certainly this is what we expect, that we believe that there has to be ongoing education if we are going to work and really provide best care in these new environments and and with all of the changes. And I think yesterday, more than a couple of the panelists talked about, it's one thing to give people that insurance card, but how do you use it, and how do you use care effectively? And so one of the expectations in this work is that there will be better patient-client satisfaction with their care and that care coordination, and that has to come with people understanding better how to use the care delivery system, and how do we figure out what is it that they need to learn so that they can effectively do that. And then certainly to manage care costs more effectively. I know that in any group, when we talk about decreasing cost, I'm not sure that that's the right terminology. We know that there's a finite number of dollars, but really we all know that we have to use those resources more effectively, and that is some of the things that we intend to do with this work. So our assumptions. First, that there is a need for continuing education, and I think for all of us, we all have our mandatory or the things that we know that we have to do for whether it's for our licensure, for our employment. And I don't know about you, but I know I roll my eyes when I think about some of the things that you have to do. And so we really wanted to, and our assumption is that continuing education, it'll be the kinds of programs and engagement that people are going to want to be a part of. And so that means that the curriculum is going to meet the needs of the stakeholders, and our assumption is that it makes a difference. These were our guiding principles. And again, probably the most important is that we used the patient-centered medical home standards, so that patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality, as well as the National Committee of Quality Assurance Standards. They really guided the principles of, as we started to identify what kinds of data would we need to gather from the providers, as well as some of the participants of care, and then certainly the core competencies for interprofessional collaborative practice, because we all know that when you talk about team-based care, it is all about how do we work together as a team, and how for all of us, no matter what level of practice, that it has to be focused on that team-based care. So what we did was we had face-to-face focus groups with our community health workers and medical assistants, people that were at the front desk, if you will, and that was identified yesterday, as we know that oftentimes our first impressions are who's the first person that we interact with. If we feel that we're invited and welcomed and expected to be there, that you are likely going to stay. You're maybe going to wait for your appointment or whatever. And so we knew that it was crucial that we included certainly everyone, the volunteers as well, in our focus groups. So we did them face-to-face, and we did them both at our medical center. So we invited people to come to the medical center, and then we went to selected sites. We did some online, so we sent out the survey to a total of about 175 people. We got a return rate of over 50%, and it was the online was primarily from the care coordinator type level. We did get some physician as well as executive level responses, but the online was primarily from the care coordinator group of people. The Medical Home Network has monthly calls with the care coordinator facilitators, and so we got some data from that group. And then the providers meet every other month, and I was able to attend a number of their sessions in order to get feedback from them on specifically on what they were looking for. And so this was the breakdown. Our N is 158 people, so that's where this information comes from. And so that's what we used as our basis to then move to identify how we were going to then begin to, really take that information and drill it down even more. And so what we identified were, and again, what we also have is both internally at our medical center, a committee that is vetting this information, and then a committee that is external with our Medical Home Network, FQHC partners, to look at all of this data, so that it's not, really very much the intention is that everything be from the bottom up rather than from top down. That was critical in everything that the way the grant was written, and then the way we are approaching this continuing ed, that it has to be, if the people that we want to be involved in this are not involved in telling us what they need and what they want, then it's not going to do a whole lot of good. And I think that was reflected also in many of the presentations yesterday. And so then we drilled down to patient engagement as being one of the absolute key umbrellas, communication, technology, teams and care coordination, and then that quality process improvement. And I will say thank you to the panel for yesterday. I will be in touch with you specifically about the technology, because we really thought when we did the initial survey that we knew what we meant when we asked about technology, and realized that we have to drill down much more to find out what do people at the clinics really mean by what do they need in terms of that technology education. So this is our plan that starting this month, so June, July of 2014, and then through October, that we will start with basic principles of motivational interviewing that Peg is going to talk a little bit more about, with really the focus on patient engagement and cultural sensitivity. And we know that it is going to be labor intensive. We have a program, and one of the people that on our faculty who is going to be working specifically with the motivational interviewing to begin with, has an online program platform. We know that specifically our community health workers and or their equivalent prefer and identify that they want their information and content face-to-face. We also know with any kind of motivational interviewing that there has to be practice. And this is where having the opportunity to partner and to be a part of an academic medical center where we have students across multiple disciplines really gives us an opportunity, and frankly gives us some of the on-the-ground labor, if you will, helps to meet student needs, but also gives us the opportunity to have them help to facilitate and to be a part of some of the groups and to help manage. So we know that for many of our sites that we have to go to the site, that they, as you all well know, an FQHC is not an FQHC is not an FQHC. And the various cultures that make up that work group is critical that we help to work within that culture. So those are the first programs. The second programs will be on team building with a focus on communication skills and certainly that active listening and those transitions of care. And again, looking at the sort of those umbrella, bigger themes, if you will, content areas rather than any specific disease-specific management at this point. And then the technology, and we know that we need further needs assessment because although the clinical sites know how to use the portal that Marilyn made reference to, and essentially what the portal does is it allows the FQHCs to see where their patients are, their clients are, over 30 days. So how many times they have accessed their primary care provider, if they've had an emergency room visit or they've gone to another emergency room within the medical home network site. So the staff at the FQHCs, they know how to use the portal in terms of looking at their clients over 30 days. but we don't really know, and that's what we thought. And in fact, both the internal and the external committee thought that that's what we meant by technology, and we realized that we have to do a lot more work on that. And what we're going to be using to evaluate the better care teams, the education, is using the Moore's outcome level. And again, those of you that are physicians in the audience know that this is what the physician groups use to evaluate their continuing education programs. But when you go down to the level of both performance and then level 6 patient care and then level 7 the community health, it really does, that model gives us a really good opportunity to meet the need or evaluate whether in fact are we meeting those patient health needs, and then are we moving to that next important critical level of population health. So now I'm going to pass it to Peg Dublin and she's going to talk about, so what does this education and what does this partnership mean for the Federally Qualified Health Center? Thank you.
Hi, everybody. I'm very, very excited to be here. And I'm an interactive speaker, and so I'm hoping to engage you a little bit. I work at Access Community Health Network, but I'm also a trainer, and I train in motivational interviewing. So I'm going to be able to talk about the benefits of the better care teams from 2 standpoints, 2 viewpoints. So let me tell you a little bit about Access. It's a federally qualified health center. It's one of the larger ones in the country. It's based in Chicago. We have about 35 clinics, and they're located throughout the city in neighborhoods that have often not had access to health care. So we have clinics all over in little storefronts. So it really speaks to access to health care that people can access right in their neighborhoods. Not everybody has a car or can try to get on a couple buses to get to a clinic. So in many cases, it's in people's neighborhoods. And we have primary and specialty care. We serve over 200,000 patients every year. And we've moved into the patient-centered medical home model, but really need a lot of help with that. And so I'm really, really excited about what this partnership with Rush might mean for us. I'm not going to read everything on the slide, but you can look at that later. So one of the things that we know in healthcare, probably everybody here knows, is that healthcare has really shifted. When I went to school in the 70s, we were all trained as nurses in acute care, in the hospital. And so there was a certain way we were trained, a certain way we communicate with patients, but everything's changed. People now are coming into healthcare with chronic problems, and 1 out of 2 of us have a chronic problem. Right here in this room, probably at least 50% of us have one that we're managing in our life. And the dollars in healthcare have shifted into managing chronic diseases. And as we get older, then more of us have these problems. So by the time most of us get into our 60s and 70s, we are managing or not managing well with a chronic disease. I could ask how many of us are, but I won't. So this is where a lot of our dollars are going, but guess what? We're not doing very well with that. And when we sort of drill down and look at what kinds of things could improve the health and suffering, we can really look at 4 lifestyle issues. Now, I am a public health person, and I know it's not just about the individual. It's really about our systems. It's about, how people live, and I know that you talked a lot about that yesterday. I'm sorry I wasn't able to be here. It's not just about the individual. It's about what kind of food do we have in our communities, what kind of policies do we have? But if we looked at the individual level, we could look at 4 risk factors that can be modified. And if we think about ourselves, probably some of these are true for us as well. Maybe not so much not access to good nutrition, but could we do better? Or physical activity. We might have access to a gym, but are we really using it? That kind of thing. But these are have been determined to be sort of the 4 key things. When they've studied why are people with chronic illness not doing as well as they could, they found about half of us, and I'm included in that, half of us are not doing, what's been prescribed. I don't always take vitamin D, and I have osteopenia. So I'm included in that. Why don't I do it? So there's reasons. There's 6 here listed, and the top 3 are things that we could actually do something about at the individual level. So how do people perceive the benefit of the treatment? How's the communication, which I would say in general is pretty bad. Why isn't there more motivation? And that's kind of my specialty, is motivation. So why are people not that motivated? Or do we say they're not motivated? See, really a lot of the issue is not about the people with the problem, it's about us on this end. We're the ones that create the discord that leads to the resistance. And anyway, that could be a whole topic. But anyway, these are things that we can actually do something about. And so again, I'm really excited about the Better Care Team, the project, because these address these top 3 things. So we need new skills. If those of us were trained for acute care illness, but really the problem is now chronic disease management, then people need new skills. They need to learn how do you manage this. They need to learn about patient self-management, because it's not about me managing you. It's about me managing me. And it's about me as a provider helping you, facilitate you to do that. And as both the speakers before me mentioned, we are now in an age of team-based care. But guess what? Our providers have not a clue on how to do that, not a clue. I've worked in primary care for many years, always bringing in community health workers. I helped form one of the first community health model programs in Chicago in the 80s. And guess what? Our providers not had a clue how to work with them. And that's true today. We have community health workers that access. Again, they're very much marginalized. And so the idea of helping health centers work as a team is really a revolutionary idea, because providers are sort of, and I don't want to offend anybody if there's a provider here, but as sort of seen themselves as, the one that can fix things. And it's true in an emergency room, right, or in a surgical suite. But with a chronic disease, it requires a team. So these are skills that people need to learn. Now, I couldn't not talk about MI, motivational interviewing, at all today, since that's my passion. So I want you to look at the next 2 slides, and I usually ask somebody to read it. Would somebody like to read this? Or maybe I will, because I have a mic. And but I want you to think about where you might see this. How many work in health centers or hospitals? Okay, great. So you're going to get to answer this question. The primary presenting problem is obesity and COPD in a 67-year-old woman who was recently discharged from the hospital. She also smokes and gets little or no exercise. Her motivation is questionable. Is this sort of something you might see in a hospital setting? You might hear it in report, right? Nothing really wrong with it, right? Right? Wrong. Okay. Same patient, Mrs. Adams. Mrs. Adams is a dependable heart of a lively and large family, always remembering everyone's birthday. She is able to manage her home and enjoy Sunday dinners with her family. Her health has not been a concern for her until last month, when she found she was short of breath walking up the stairs. She was told to quit smoking and it took 2 hours to get to this, as there were many other things she wanted to talk about. Same patient. What's the difference? Please speak up. Right, and why would that be important? Yeah. Yeah, and it's funny because I was teaching some students about this, and I showed them these slides last week, and this one budding nursing student said, "Well, I don't need to know all that. What do I care about if she can remember people's birthdays?" And I'm like, "Yeah." And the other student said, "But now we know what motivates her." And so the whole principle of motivational interviewing is not what are all the statistics about COPD and why smoking is a problem, but is what will motivate her to make a difference in her life. And Mrs. Adams, what does she care about? Her family. And the fact that she remembers everyone's birthday means that she's at the center of this family. And so for her to quit smoking, it's not about my facts about smoking, it's about being around for her family and all those birthdays. So if I know that and I've talked to her about what's important to her, then I'm going to be able to find her motivation, and she's going to be able to find her way through this. And so that's why the second one is where we need to go in healthcare if we really want to help people manage their problems. So this requires a different mindset, doesn't it? And like that first nursing student, I was sort of shocked because she's new. You know, she hasn't even had years of bad practice. And so, but at least I got her while she was still a student, and maybe we'll think about that. So, you know, what is going to help us at Access? Now, here's the irony of it all. I've been an MI trainer for 10 years. I'm a member of the Motivational Interviewing Network of Trainers, and I work at Access. Wouldn't you think I'd be a gold mine for them? But no, I have barely, the only people I've trained in MI where I work, where it wouldn't cost them a nickel, is on my team, Maternal Child Health. I've trained all our outreach workers, community health workers, and care coordinators. But we have a whole lot of doctors, and there's 900 people that work there. And we're moving into patient-centered medical home, and at the heart of that is patient engagement. At the heart of MI is patient engagement, but I haven't trained anybody. So here's the irony, is that through the medical home network that we're part of and partnering with Rush, they'll be bringing in some training or we'll be coordinating in some way. So it is legitimizing what I have been talking about with our CEO, with our medical director for 10 years. So that's kind of ironic, isn't it? But it's often the case, right? The plumber doesn't have good plumbing at his home. So, and I really hope that this is going to lead to better, that people will be able to work in teams in a lot better way, learn how to work with the resources that we have already, because we're rich in resources where I work, but people haven't figured out how to bring together, you know, the care coordinators, the community health workers, the front desk staff. We don't work as a team, we work in silos. So I'm really, really excited that this may actually help to change our practice and, of course, to strengthen our relationships. So thank you very much.
I promise you I'm not starting all over again, just one final slide to tie it all together. As I mentioned in the opening remarks, rigorous evaluation is part of all aspects of the project, with many of the project components playing into very same or similar outcomes. But at the very end of that slide, there's the word replication, And as much as doing the project itself and assessing it, dissemination and replication is another key aim of ours. So I'm sure that as you were listening, many people had ideas or thoughts about your own organizations when you listened to the project rationale and the descriptions, but I know that cost is always a factor. So short of receiving a $5 million grant, we had already been doing some aspects of this work before we had this money without funding. So I would really urge you to capitalize on any existing partners that you have, in particular finding universities or colleges in your area with healthcare and health system programs, our academic medical centers to be partners for you in establishing and executing any needed training programs for your staff. And while, we of course have funding now to accelerate all of this, we're happy to talk with anybody offline or during the Q&A session on how to engage your academic partners at little or no cost to you to do a better care team type of project. And I know that we have a few, could have more than I know of, but a few academic representatives in the room who could attest to the fact that they all have lots of graduate students that, yes, while they're out there learning, they always bring great value to the community in the work and the projects that they do. Thank you.
Thanks again to the whole panel. I would toss it now to anyone in the audience. We have a little bit of time. If folks have comments, observations, or questions, feel free if you just want to raise your hand. And Devin has the mic for you. Over here to Kate.
I'm not really clear on what the better team training, the targets of that. I understood that you were doing some training with CHWs and MAs, but there's a whole, must be a large structure of training, and maybe you talked about it and I didn't hear it.
Sure.
No, and I probably wasn't clear. The training is designed for and will be delivered to providers, including our physicians, nurse practitioners, physician's assistants, and then and I use the care coordination umbrella loosely. Essentially what many of the FQHC clinics have identified is anyone that is licensed, they see, so, our social workers, whatever, more in that group, and then the community health worker, medical assistant level. So there really will be three, and it will be the same objectives, but the content delivered differently. Again, because from our needs assessment and from our focus groups, particularly the group of providers on the ground, if you will, have identified that they prefer face-to-face, and the care coordinators and the physicians have identified that they are interested in doing some online with then a little bit of face-to-face, mostly simulation.
I just wanted to add, Kate, to that the training will not all be siloed, just discipline specific, but they'll be trained as teams, and then there may be things that will be more discipline specific, mainly because they prefer to get it in a different kind of way. Our opening kickoff that we did was everyone came together for interprofessional, because that's a big underlying aim of this. So it will be a mixing of the pot of people also.
Thank you.
Other questions or comments? Yep.
Hi, could you describe how you're recruiting the allied health trainees, and are you connected to high schools, and how you're processing the scholarships?
Sure. The question was, how is the team recruiting allied health professionals, including through high schools, and connecting them with scholarships?
Well, I had mentioned the RICSIP program that Rush has had for a long time, and we have a lot of healthcare pipeline programs that we've also had for many years since the 80s. So we were doing STEM pipeline training before STEM was in vogue, science, technology, engineering, and math. And so we're connected from preschool on through high school. Another big connection we have is Chicago Public Schools now has a medical prep school, and it's been one of our partner schools for over 20 years. We've had a health clinic and health center in that school, so that's another pipeline coming in. And some of the scholarship that we did this for the career ladder, because that was already going on. So we have a career ladder where people will come in from Malcolm X Community College with an associate degree in respiratory therapy or PA or some other areas, and we have it so they can seamlessly transition into Rush. We also have another, and I'm embarrassed to say I forget the exact name of the bachelor's degree program, but it's a basic health science, so then it could be a launching pad to a variety of graduate level. And one thing that we've had to do, while the city college tuition can be very affordable, and because of where our students come from, quite often they'll have their tuition completely covered. Coming into a private university or even a state university, it's very expensive. And I know that we have done, particularly for some classes as a whole, complete tuition forgiveness. And of course, that's limited of how long you can continue to do that. And we have private funders now through our philanthropy department, families that are donating large hunks of money to keep some of that going. And in regards to identifying, of course, it's student choice, just like it's patient choice, about what you want to do or where do you want to go on to, but the faculty and deans at Rush University have worked closely with Malcolm X in regards to identifying students and helping to assist students along, not just with money and buying laptops and books, but with individualized tutoring or whatever supports are needed.
So we're going to break soon. I had one observation I wanted to make, which was I thought it was really critical what Beth-Anne said around designing this whole project and the whole training based on what your constituents wanted, not what you thought they needed, which of course is a lesson every health center knows. But I would say where academic and health center partnerships usually fall down is when they don't make that realization. We all learn about the golden rule of treating people as you would want to be treated. In a partnership like this and in the communities you serve, that's not good enough. The platinum rule applies of treat people as they want to be treated. So as you think about developing these partnerships, consider how would they want to be treated, because the way an academic medical center wants to be treated is very different than the way an FQHC wants to be treated. With that in mind, hopefully Karen and I and our teams have treated you the way that you want to be treated this week. Thank you again for coming, and I would ask if Karen has any final thoughts before we break.
Well, yeah, just remember, this is something new for us this year, is tweet. I have not been a tweeter, but I am learning, so it's actually kind of fun. So if you would tweet those questions or comments or respond, it just starts a ripple of conversation, and it gives a voice to this effort that we're all here about. So again, thank you. And so we'll transition at this point.
Could I make one
Absolutely.
comment? Yesterday in the afternoon panel, one of the things that every panel member identified was that importance of that partnership, and truly it being a partnership and there being that good communication. And as I was sitting and listening and thinking about the opportunities that we have with this grant and with this work, that really is one of the absolute non-negotiable guiding principles, and that is, that it is about what our partners have identified and want and need, not from that top down. So thank you to the panelists yesterday, because you really hit home absolutely on the importance of that. Thank you.
Thank you. One final thing as we transition to the breakout, because this will be the last opportunity that we'll all be together as a group. I just really wanted the conference staff that did the planning to please stand. They have done just a yeoman's job on this. Thank you. They may be out in the hall, but if Rachel and Christine are nearby, you see them, give them a hug or a big thanks, because, you know, Rachel emailed me at 1 a.m. with some talking. There's Rachel. There's Christine. So we really, really thank you, all of you, Jose, Johnette, Alex, and who am I forgetting?
Oh, there's too many to name.
But they have really done an outstanding job. So we really appreciate, and we appreciate you for participating and continuing to the 11th hour. Thank you.